Yeah, so good morning. So I'll be talking about the ROP screening methodology. So WHO estimates that 15 million preterm births are happening every year, and India is having the highest number of preterm births. That's why it's very important that we have an ROP screening programs in place so as we can detect all these children for ROP and contribute a lot to the prevention of ROP-related blindness. So how to detect ROP in time? It's very important to have a tie-up with your neonatologist so that you can establish an ROP screening program in your NICU, in your hospital, so that you can collaborate together to detect ROP through our ROP screening program. A good ROP screening program helps to identify babies at risk, ensures timely detection, prompt treatment and referral, and avoids unfavorable outcome. So where should you screen for ROP? You can screen the NICU, and NICU is the best place because the pediatrician can tie up with the normal weekly visits of these babies, and you can go there once a week, and at a pre-fixed time they keep the babies dilated and you can screen these babies for ROP. Or if you have an eye hospital where a significant number of babies come, then you can have an ROP clinic where these babies can again be called once a week and you can screen these babies for ROP. The important question is to realize whom to screen and when to screen. So this is a photo of the global gestational age data, which if you will see on the left side, there is countries like UK, US, the developed countries. You see much smaller babies develop ROP in these countries, whereas if you see in countries like India marked by the arrow, bigger babies develop ROP. Similarly, if you see the global birth weight data, you will again see that smaller babies develop ROP in developed countries, whereas bigger babies develop ROP in developing countries. So which basically means that if you see the international guidelines given by the American Academy of Pediatrics, American Academy of Ophthalmology, so they say that you screen babies less than 30 weeks and less than 1500 grams. So that is the American guidelines, but you see in our country, because of improved survival, while on one hand very small babies develop ROP, on the other hand because of poor NICU care, bigger babies also develop ROP. Therefore these guidelines are not applicable in our country because we need to screen a larger number of babies because all of them tend to develop ROP. So which guidelines should be used? So different societies have given different guidelines. I prefer to use the ROP guidelines given by the Rashtriya Bal Suraksha Karyakram. It was also endorsed by the National Program of Control of Blindness and was endorsed by a large group of ROP experts across the country and the National ROP Task Force, and it's on the National Health Mission website if you want to download it. And what do the guidelines say? The guidelines say you should screen babies less than 2000 gram birth weight and less than 34 weeks gestation age. And you can also screen babies from 34 to 36 weeks gestation age if they have a large number of the risk factors which are there, like they require cardiorespiratory support, have RDS, chronic lung disease, blood transfusion, sepsis, and so on. And when should you screen them for ROP? So you should screen all these babies within 4 weeks of life or within 30 days of birth, or 30 din roshni ke, as Dr. Jalali likes to call it. And 2 to 3 weeks of age also you can screen these babies, if for smaller babies who are born less than 28 weeks or less than 1200 grams, you can screen these babies as early as 2 to 3 weeks to detect aggressive posterior ROP, as Dr. Anil told you. So we'd also be happy to know that the RBSK program covers 30 selected childhood health conditions for screening, detection and free management, and ROP is one of those diseases. So you can opt for this in collaboration with the government to perform this activity for free. And there's also the JSSK program which is there by the Government of India, where again it provides children less than 1 year free transport, diagnostics and free treatment. So if you tie up with this program, you'll be able to provide free screening services and treatment for these babies. How should you screen these babies? So it's very important to explain to the parents in detail that what problem their baby has, and the important need of follow-up. That is the most important thing, and the next most important thing is to have it all documented through informed consent. The date of follow-up should be clearly mentioned on the discharge cards, on the follow-up cards, so the parents know. And just writing them is not enough. They have to be explained about what is ROP, why it's developing their child, what they can do about it, and it's going to increase or decrease, etc. So when starting screening, the baby should be warm, dry and fed. You have to use all kind of sterile instruments. Aseptic measures have to be taken. It's a very cost-effective strategy. You just need a direct ophthalmoscope and a pediatric depressor, a wire speculum, and that's all you need basically to get this thing started. You can just do it once a week. On the right side you see that these are the eye drops which you make at our center. It's half dose strength of the adult dose. So because we have a large number, so they make it at our ocular pharmacy, but if you want to use it in your clinic, you can just dilute it 1:1. And so you can have phenylephrine 2.5% and tropicamide 0.5% combination, or you can use them separately as well if you want, 2 times 30 minutes before the procedure at 10 minutes interval, and that works very well. So when doing the screening procedure, you need to examine the anterior segment, look for tunica vascular lentis, identify the zone, stage and plus disease, which Dr. Anil has just told you about. Examine all cars, start from the nasal and then to the temporal periphery. So you realize that the nasal retina forms first and temporal retina will form later. So if all of them are vascularized, then it's all done. So scleral indentation is a very important part of ROP examination because you're doing this procedure in a topical anesthesia. But the babies are so weak that just by scleral indentation you are able to move the eyes, helps to stabilize the eye, rotate the eye, indent the periphery and contrast the structures of interest. But it's unlike an adult eye where you can indent very severely and nothing will happen. Here if you indent with too much pressure, it's going to go to corneal haze, conjunctival hemorrhages, etc. So you have to be careful and just do it gently. Because the patient is very cooperative. Wherever you move the eye moves there easily with the scleral indentation. And very important to record all this correctly because of the medical legal age which is coming. You have to possibly follow up for a long time, and the record should be very clear, especially if you are referring to another doctor about the disease regressing, increasing, decreasing. So you should be very clear about, and it should all be recorded very correctly. I'll just discuss some few challenges which are there. The most common challenge which people encounter when they start screening is the pupil does not dilate. So the pupil does not dilate, you need to realize the most common cause is that the eye drop has not properly gone into the eye. So you wait there half an hour and you sit there and you put the drops yourself in front of you. Otherwise what happens is the eye is so small, you put the eye drop, the fellow blinks and the eye drop just goes outside. So it doesn't work that way. So you have to do that. Secondly, they might be putting the wrong drop. So many times in our place they, instead of putting the dilating drops, they are putting antibiotic drops. So it doesn't dilate like that. And even if after that half an hour it doesn't dilate, then you have to look for plus disease. That means the pupil is not dilating because he has plus disease. A severe activity is going behind, and you can have a lot of neovascularization of the iris as you see in this photograph. So in these cases it is very much important that you go back and you look behind. At least in all the cases you might be able to see and look for plus disease, and then you can proceed with further management. So the idea is not to say you come back after 2 weeks, pupil is not dilating today, maybe I'll see you next week. You see, next week is going to be even worse. If you have a plus disease sitting there, it's going to get worse, the disease is going to get worse, and what could have been salvaged today, you might not be able to do it next week. So if it doesn't dilate, you have to go in and see why it's not dilating. You should have a high index of suspicion of aggressive posterior ROP. If you open the pupil, if you open the eyelids of a small baby, you will see something like this. This meshwork is tunica vasculosa lentis. It is a normal finding in very premature babies, and over a period of time, this meshwork tends to disappear. But in case of aggressive posterior ROP, sometimes with severe plus disease, it can become very angry looking. You should always look behind and see what is there. So aggressive posterior ROP is the single most common cause which confuses even experienced users, because you really don't know where the junction is, where the ridge is, and you keep on looking for it and waiting for the disease to come, but the disease is often very severe by the time you get it. So just to show in angiography, just to show you that the blue arrows is where the apparent junction seems to be, but if you see the red arrows are where the actual junction is, and a lot of these avascular loops are there, and these are all areas of potential ischemia which need to be treated. This is another case just to show you like that. This is a case of albinism. If you have a case of albinism, again you see the ridge is coming here, very difficult to detect it in time, and you have to again have a high index suspicion that ROP might be occurring in this baby. Very difficult to treat, very difficult to see. And till when should you screen? So you should follow up from 1 to 2 weeks, depending on the zone stage of the disease, and you follow up till the retina is mature, which basically means it is 1 disk diameter from the ora serrata, or the disease regresses spontaneously on its own, and this usually happens by 40 to 45 weeks of post-conceptional age. And if the disease is severe, you can go ahead and treat the disease, and it regresses, and you follow up till the disease regresses. Obviously there are other treatment protocols for anti-VEGF and advancing ROP, which will be discussed in the later talks. So is there an easier way to screen for ROP? There is wide field digital imaging which has become very popular. On the left too, you see the models of the red cams, and the right is an indigenous model, the Trinetra Neo, which has been developed in Bangalore. And these are different wide field imaging cameras which are there, and they basically you have to just put the camera over the eye of the baby and you can have a photograph. And it's very easy to screen through this, but it doesn't give the 3D picture which is provided by the indirect ophthalmoscope. It's a mobile self-contained system, useful in the IC198, can be easily used by technicians or nurses, avoid the stress and expertise of indirect ophthalmoscopy, and is a useful teaching tool for residents and parents. But the major limitation is that it's very expensive right now, and probably more indigenous models will come in which will make it cheaper. And a lot of these telescreening apps have come into the market which allow experts to sit at one particular center and telescreening mobile vans to go across the country and in areas where screening is done, and they can send you the images and you can report through that. And Dr. Anand is here. He runs a very successful kid drop ROP screening program, probably the largest in the world in the districts of Karnataka, and a successful model and the best model for ROP screening through telescreening model, and many other models are now being replicated based on this model. So sitting in Coimbatore, I think I would be failing my duty if I don't, tell this study by Dr. Parag, who is our chief instructor also. So this was a knowledge attitude practices study which was done in pediatricians. How much do we really know, and what is the level of awareness which is there in our community about ROP? So this was knowledge attitude practices questionnaire for 83 pediatricians in Coimbatore, and 65% pediatricians were aware of ROP only, and 39% knew that ROP is preventable. 41% did not know what part of the eye it was affecting. 45% did not know when to screen for ROP, and only 43 were sure that ROP is a treatable kind of disease. So you see, this is not a gap only in this particular city, it's a gap throughout India. Many other studies are there which quote similar results. There's a huge gaps in the knowledge of awareness among pediatricians, ophthalmologists, and the general public at large. So we need to spread awareness about the disease and let people know what this is, and that every child needs to be screened. And obviously, if you don't screen them, what happens is that every child is going to go into stage 5 ROP if you don't screen them. Obviously, many of them will spontaneously regress, but if you have severe ROP coming in and if you don't screen it, is going to go into stage 5 ROP, and the child is going to become bilaterally blind. So there are a lot of the medical legal cases coming up right now, and you need to be aware that basically caused due to lack of screening. So if you don't screen these babies in time, and the only way to screen these babies is through an ROP screening program. So if you don't do it, these babies are going to go blind. And it's not a new disease, it's been around for decades. There are clear-cut national and international guidelines for screening and treating ROP. And if we don't screen and treat ROP in today's days and age, then these babies are going to go blind, and it's going to lead to these medical legal cases. So I conclude by saying, that an effective ROP screening program is the key to prevent ROP blindness and the right of possibly every preterm baby which is born in the world. Thank you so much.
So thank you, Parijat. Just a few comments. You mentioned that take consent for screening for ROP. Now,
yeah, so
do you usually take consent for screening of ROP, or?
It's a general kind of consent when the patient enters into our system, so that we basically don't take it specifically for that.
Okay.
Yeah.
So it's a generalized consent which
generalized consent is
every
taken,
patient who walks in the hospital.
It's taken for who enters into the ROP program. Yeah. Okay. We take it in general. So that's there. Otherwise, many places don't take it also.
So that's the same consent which is essentially taken for all the patients, even the general clinics, and that's the same consent.
Yeah.
Form.
Yeah.
Okay. Right. And yeah, please. So put on the mic, sir. Put on the mic. It's off.
Many a time, when the doctor said patient kids for ROP screening, most of the time, many kids has got a simultaneously congenital nasolacrimal duct obstruction, and sometimes they get discharge and conjunctivitis also. So in that case, the waiting for another 7 days, like, it feels too risky for me. So how do you?
You see, you should continue to do the ROP screening. The congenital lacrimal duct obstruction will gradually, resolve. Many of the babies are premature. The pathway has not formed in time. So many of them do, I agree, have this kind of discharge and do have watering and all. But we should not stop and delay the ROP screening because of that.
Because sometimes because of infection, because of conjunctivitis, when we are
if the conjunctivitis is there,
fear of some corneal abrasion might lead into corneal.
If the conjunctivitis is there, then possibly if you do a lot of splendid additions, it will cause a lot of bleeding and hemorrhages and all. But there's no harm in just looking back, and even if you don't want to put a speculum, don't want to put indent, you can at least look back and see what the stage of the eye is. Maybe in 3-4 days the conjunctivitis will subside, and then you can again look into it in more detail.
Thank you.
If a child weight is doubled in 6 weeks, should we continue the screening?
If the child's weight is doubled?
Yeah.
So it's not related to weight. If you have an increase in postnatal, obviously the severity is expected to go down, but that does not take care of the ROP. You have to screen for ROP as per protocol till the retina vascularizes into the periphery and it's mature or
the chance of death becomes less, right? After if the child weight is doubled in 6 weeks.
Sorry?
The chance of child going into for laser for ROP.
No, if you have good weight gain, then the risk factors start going down, and then possibly the child might not develop severe ROP, but it's not exactly related to this. Yeah, so if a child is sick, there's high risk that he will go to develop ROP. But that should not be clearly linked that if the weight gain is happening, then maybe I will not screen, or maybe I'll screen later. You should follow the protocol for screening for ROP despite the weight gain.
Just wanted to add the conjunctivitis because 2-3 months back we had an epidemic in the southern states, and in Karnataka we do the entire imaging through image based. But during the epidemic, any baby was suspected to have conjunctivitis or of course had frank conjunctivitis. We withheld the RETCAM imaging. We did not do it with imaging, but we just, without using, as he said, a speculum, just opened the eyes, pries open with the disposable plastic gloves, the transparent one, and just had a quick look at the posterior pole. So we did not dilate, but we certainly avoided, because otherwise membranes formed very easily in this particular epidemic. And the second question on the weight gain, we've recently published a paper on the regaining of the birth weight. As we all know, babies lose weight about 10% and then they regain it. We looked at how soon they regain. So any baby who regained it within 10 days after birth, in our cohort of about 80, did not develop any ROP. And any baby who took more than 24 days to regain the birth weight developed treatment requiring disease. And there was a middle moderate risk between who took about 14 to 21 days who developed some ROP but not treatment requiring. So weight gain and weight loss after birth seems to be important, but that does not absolve you of the duty of doing the ROP screening. It can just be used as an indicator.